Ivan, in patients that have had an ACL rupture, what are your thoughts on whether they've injured their ALL as well? Do you think it's common that they injure the ALL or less common that they injure the ALL?
No, I think it's quite common, ALL injuries. And again, like you said, whether you do anything about them is really dependent on the presence of a scone fracture, the degree of the pivot shift, just the factors that draw on.
So one of the problems with diagnosing it is when you look at the MRI, the MRI slices are taken out of the plane of the anterolateral ligament because it's typically done with the knee in extension, and so they're trying to isolate the lateral collateral ligament on the left side to see that, and in the horizontal slices and the lateral view, you tend to miss it by about 2 millimeters. So they have to do very, very thin 1 millimeter slices through that area to pick it up. And I think it's only now that the MRI guys are doing much finer cuts in that area, we're starting to diagnose it better on MRI than what we used to. In terms of what's a lateral femoral notch sign, when you get a compression fracture of the lateral femoral condyle and you look at the lateral x-ray, you'll actually see a divot taken out of that lateral femoral condyle. And I'll post that up on the Orthosports site with an image and an arrow if you want to see that. Andreas, is there any evidence that the registry data improves patient outcomes?
I think that's unquestionably so, both in Australia and elsewhere. Now, the federal government funds the registry, and the funding is approximately $2 million a year for statisticians, computers, housing, and the like. And so the federal government actually asked Boston Consulting to look at the cost benefits of the registry, and Boston Consulting looked at the numbers and looked at the likely influence of the registry on surgeon behavior and the fact that we have saved a great deal of revisions in the community by changing the habits. And so they have calculated that in the time of the registry, Australia alone has saved about $600 million. So that's an amazing cost benefit for the federal government. Put 30 million in and get 600 million out. I think undoubtedly yes.
Fantastic. On that question, do we have any long-term results of hips like the Superpath, which has sort of become very trendy lately?
The Superpath is not a hip replacement. The Superpath is an approach. The Superpath is linked to a particular hip replacement, but it's not actually a hip replacement. We do not have any long-term data, and I suspect it will come and go like many one-day wonders.
So if you look at patients, you've got a 90-year-old patient that comes into the emergency department with a hip fracture. How do you decide whether that patient should get a hemiarthroplasty versus a total hip replacement? Can the registry guide you with that?
Registry data is available, and registry data has been split up into the various causes, and there's in fact a subsection now for fractured neck of femurs, and we have so many of them in Australia. In addition to the registry, we also now have the hip fracture registry, although their results are much shorter because it's a much newer registry. The hip fracture registry, in addition, also has patient-reported outcome measures, PROMs. And so that'll give some answers which our National Joint Replacement Registry does not give. But in general terms, the function of a total hip replacement will be better for a community ambulator. For a 90-year-old lady, one always has to consider the comorbidities, the cognitive ability to cope with a hip replacement, because the dislocation rate will be higher for patients like that as opposed to hemiarthroplasties, and is of course a slightly bigger procedure. So in those who have cardio respiratory compromise, one may choose a quicker and smaller procedure. So these are general guidelines, and the registry does give some indications, but the registry is not a how-to-do book. The registry presents data which surgeons should interpret, and we are trying to help them doing so.
Okay, very good. Ivan, you mentioned patients needing osteotomies if they were in varus. So if you had somebody like a professional soccer player, what would the effect of doing the osteotomy in that patient be?
It would probably end their career.
Probably
in their career. I spoke, there was an Italian surgeon I talked to who looked after a lot of the Serie A players, and his opinion that a high tibia osteotomy would basically be the end of a high elite professional soccer player. There's one soccer player in the A-League, it was quite controversial, Jason Kalina, who came and played for Sydney for a couple of years, but had some, I'm not quite sure of the exact pathology, but he ended up having a high tibia osteotomy. And then his father, happened to be the coach at the time, started coaching Newcastle and signed him to Newcastle for $1 million, and he couldn't play. So there's a big legal ramification. But generally the shift, I think the change in the alignment of the LR leg and that sort of level of soccer player, I mean, they'd probably played social, recreational soccer, but it'd be enough to finish them. Generally.
Interestingly, if you look at all the really good professional soccer players like Maradona or Pele or Beckham, any of these guys, you look at their legs, they're all in varus.
Yeah.
And that allows them to turn faster, and that's why they can get around other players, is because they can plant their foot and twist and turn faster than what other people can. Their centre of gravity is much lower. It's much more efficient for them to sidestep. But it's also why the re-injury rate after an ACL reconstruction in them with a hamstring tendon reconstruction is higher. And in those professional soccer players, virtually all of them now have patellar tendon reconstructions rather than hamstrings, because it's a stiffer graft which is more durable in that situation. The failure rate in professional soccer players of a hamstring reconstruction is 15% higher than a patellar tendon reconstruction. So the elite athletes, we're definitely drifting back towards patellar tendon reconstructions in that population group.
Those patients group, were you more likely to do something about the ALL or a lateral
Lemire or something.
Yeah, or a Lemire procedure, something to tighten up the lateral capsule and reinforce it.
Yep.
Yeah.
Not only soccer players, but probably the group of patients who are those risk takers, namely the 20-year-olds. Their re-rupture rate is so high because of a whole lot of other activities.
Yes.
That one has to consider whether that's worthwhile, because the figures are equally bad.
Yes, I agree. There's a question here. Does the indication for isolated MPFL repair change in adolescent kids that are having recurrent dislocations? And I'll get you guys to answer this as well, but my answer to this is the more times they dislocate, the more likely they are to have chondral damage. So if they don't have chondral damage initially, they will fairly quickly afterwards, and it depends on a lot of the other factors, the femoral anteversion, the torsion, etc. But if they've got reasonably normal anatomy, even as an adolescent or a teenager, I will do the surgery, being very careful of the physes, because most of them are quite miserable. They can't participate in sport at all at school, because every time they do anything, they dislocate their patella. Andreas, your thoughts?
Much the same.
I think you have to be almost more aggressive in adolescents with this sort of problem than older age groups, because they're going to destroy the articular cartilage very quickly. It's the same with dislocations and shoulder dislocations in young patients we might talk about earlier, but they need to be stabilised early, because they're going to destroy their joint before they're 20.
Yeah. And so, in fact, the old thing of waiting till they were skeletally mature before doing the surgery, that was only necessary if you were doing a bony reconstruction and doing something to the tibial tubercle, because that would affect their bone growth. But because we're not affecting the growth by doing the MPFL reconstruction, it actually allows them to grow more normally and participate in their normal activities. So Andres, you've got a theoretical patient here, not done by someone in our group. He's come to see you because he's had an MPFL reconstruction, but he's very tight and he can't actually flex his knee properly and he's getting some anterior knee pain. Can you talk us through what you're thinking when you see that patient? Or would you like Ivan to start first?
Okay, well, you're thinking bugger, but I mean that's difficult. So you know what? You looking at the MPFL reconstruction, you wonder whether they've got the insertion places in the right place,
Yep.
Whether it's been over-constrained just by over-tightening.
So now you actually look at the insertion site and you think, oh, look, it's actually a bit proximal and it is overloaded. Can you do anything about that?
Yeah, you can revise it. Yeah, it needs a revision. It's the same as anything. You know, if it's not right, it needs fixing. Yep.
Ron, the question is a little bit like an exam here, where one tries not to insult the examiner.
That's right.
Who's probably done the other operation. And so from a very theoretical point of view, sure, we get that occasionally that something's overdone and you have to consider redoing it.
Yeah.
You may need to, I mean, these are cases which we have from time to time, which we present to each other. These are cases which we approach with a great deal of caution. These are people who have probably gone through a good deal of rehabilitation with physiotherapy, with as best as one can. And one has to also look, is it actually that tendon which was put wrong? Is there some additional scarring? We have some people who get a very nice operation, but their soft tissues are unforgiving and they scar. We get that with total knees. You do exactly the same and you struggle afterwards, and that's a question of how that person heals. And I'm sure that if we do more patellofemoral ligaments, we're going to get a few who need revisions.
Yeah, and there seems to be a higher rate of that happening as people are using synthetics, because the synthetics are very unforgiving. If you put in a patient's native tissue, there's a little bit of stretch associated with it, and so my personal feeling is that most of the time synthetics in this situation are not such a good idea, particularly in a country where we have access to allograft tissue, as opposed, you know, if we don't want to take the patient's own hamstrings. Ivan, grade 1, maybe early grade 2 posterolateral corner injury conservative treatment. What's your typical protocol in that situation?
Generally, I put them in a range of motion brace for 6 weeks.
Do you allow them to weight bear? Do you allow them to...
Yeah, usually allow them to weight bear within the brace and just sort of increase like maybe 0 to 30 for the first couple of weeks, then 0 to 90. And then at 6 weeks out of the brace and more aggressive, strengthening and rehabilitation from then.
Andreas, any different?
No, but the big question is when to allow them to get back to sports, and that's where the arguments are, because they're always pushing, and we have this sports mad society, and well, it is, healing takes a lot longer. We tell people who break the distal radius that'll take 6 months to get better. You try and tell a young sportsman that takes 6 months. They think something's wrong with you, not with them.
So, I mean, the other injury that often happens with these big posterolateral corner injuries is the vascular injury. And the last 2 patients that I've dealt with at the public hospital have had no pulse in their foot. And so, the first priority is to restore the blood vessel. But, then you've got these massive cuts from the vascular surgeons. They've got, they've done a fempot bypass or whatever it is. Then, you've got this nerve floating in the breeze. And then they say, okay, well, you can't move the patient. You can't operate in the posterolateral corner. You've got to put an external fixateur on them. So this is not necessarily a straightforward patient that you have to deal with an order of priority. And if you do see one of these patients that have had an injury on the weekend that you think has dislocated their knee, don't assume that it's just a ligament injury. Check their pulse very carefully and also warn them that they should probably get some at least vascular studies done to make sure that the blood supply has been restored to the foot, because it is potentially a very serious injury. Andreas, you said that some of the prostheses are better historically than others, and so we shouldn't change. What are your thoughts about limiting innovation and new developments by following that pathway?
Collectively, that's exactly what we've done. In the past, we relied on laboratory data, we relied on company statements, and that's actually what got us into very big trouble with the ASR prosthesis, which caused all those revisions of metal on metal. That company simply claimed that their prosthesis was similar to the Birmingham, which had been passed, and they showed that even though two things look pretty similar, some very minor differences can cause a catastrophe. So now we have actually, not just we, when I say we as a society, so the TGA requirements are much, much stricter, and we now have to have at least 2-year patient data before we can introduce things. And so prostheses, new prostheses, have to be introduced with a protocol which is much more onerous than we had in the past. Whether it's good enough, we hope it's good. There is always the hope that some new things are better, and we don't want to stifle innovation altogether. But it's interesting to note how good old devices were compared to new ones.
Very good. All right, I think that's a good note to finish off our panel. Thank you very much.